Milton. Good morning. So I have 15 minutes to tell you what I know about telehealth, and as Milton was just referencing, we have, I hate to use the word failed, but we've failed a whole lot, but we've pivoted through along the journey. I started my first work in telehealth in '99 and went live with my first program in 2003. So there's been quite a big change in the market, the industry, and the adoption and the willingness of people to do telehealth. So it's come a long way, but I'm still standing and it's still growing, so you can do it as well. So I'm going to jump in and just go through a few slides just to kind of give you a snapshot of how I'm thinking about virtual care in telehealth now, because I'm not thinking about it in the traditional way that I think most people do. So I'll do that, then at the end we'll have a time for some Q&A. So just for some bearings around the organization that I'm with now. So I'm at Ascension Health. I'm based in Austin, but we are in 22 states in DC. So we're a very large organization, over 160,000 employees, over 13 million physician visits, over 150 hospitals, and the list goes on. And one of the reasons I came to this organization from the academic medical center where I was because of that playground. So I thought, if I'm really going to make a difference in healthcare and be able to take what I know works from using telehealth and virtual care services, I need to be in an organization that's larger, that has resources, have patients all over the United States, that I can start integrating that into the practice. And so what I've started doing, I took those lessons learned from the 15, 18 years of work before coming to this organization and said, what were those barriers and why did it not work and why did it not get great adoption? Now, mind you, I was doing 8,000 telehealth consults a month, and we had a statewide operation that was integrated into over 100, probably over now 200 locations. Of organizations that were not owned by us, that were community-based, that had different boards, different electronic medical records, all those challenges. So it was still a success, but it was like every day just kind of trying to convince and willpower to get through it. It took a lot. And so I decided when I moved into Ascension that I wanted to look at it different. This was a part of your access strategy. I didn't want to have a center for telehealth over here and go in and try to give people tools and convince them to use us. I want this to be at the point of entry. And so I'm going to talk about how we've integrated not only all of our access strategy, but navigation, care coordination, virtual care, care management, all under one roof. And there's still a ton of that happening virtually, but we've coordinated it into one building so that the teams could really work together and kind of unleash the full potential of what virtual care has to offer. And so if I think about access services, what we started with was, I didn't want somebody to have to call somewhere different or go into a different portal to get a telehealth appointment. I didn't want the physicians or other providers to have to go into a different record or a different a platform to do the work. So what I did was I pulled all the scheduling for all of our ambulatory clinics. I pulled all of our transfer center and bed management for our hospitals into the same building as well, and imaging scheduling into the same location. So what happens is, if you needed to call in for an appointment, the same team that's scheduled for virtual care, scheduled for brick and mortar face-to-face visits, the same team that you called to get a patient admitted and put them in a hospital or transfer them to the hospital was the same team that did virtual care scheduling. And so let me take it through a real life scenario. A hospital calls to transfer a patient to us. Now we can say, hey, instead of moving that patient, let us bring the doctor to you through virtual care, and just do that. If you called for an appointment for yourself, we could say, hey, you know what? We can do that right there at your home. All you need to do is download this, and the same doctor you would normally see in person, they can see you there. And so then we just book it into the physician's regular schedule in their EMR. So they may go into exam room 1, and then they may go into their office and see a patient that's hundreds of miles away. And so really getting into the workflow of the care team, as well as to the life flow of our patients that we serve. And so it really made a big difference. Now it's not an adoption issue. It's just around booking appointments, and the providers or the patients just access it in whichever way is most appropriate. So that was really a pivotal moment for us. So it didn't go without lots of bumps for anybody in the room that's centralized scheduling for clinics. You know how tough that is. So that's a whole nother presentation, but it really worked well for the adoption of virtual care. In our hospital services, what we did was we pulled anything where there was care being delivered that could be done remotely. And instead of having all these teams and all of our different hospitals dispersed and siloed working, independently, we pulled them together and gave them the technology so that they could remotely serve all of our hospitals. And we started doing it in the Texas market, which was 11 hospitals, and now we're expanding, and I'll speak to that in a minute. But what we started with was centralizing telemetry, centralizing our what we call a clinical surveillance unit. So we have all this ability to monitor data points, but data overload and no one really knowing how to make that information actionable. So by putting these teams together, putting centralized telemetry, our e-sitter program, and our clinical surveillance teams together, they mine that information, look for trends and things that need to be acted upon, and then escalate to the appropriate person at the bedside to do that work. By centralizing, we're also able to load bear the work, and of course, with that comes financial gains and a more lean operation. This includes our same work with on-demand interpreters, any telemedicine that we need in the hospitals. That all lives under this arm of our work. The virtual care services really is around a team that is responsible for integrating this work into the workflow of our providers and thinking about it from the experience side from the customers that we serve. So it's a lot of project managers, clinical informaticists, and those types of people. The clinical teams are already out there. We just have to get it into their workflow. So this team's going around and saying, hey, how do we turn your practice into a virtual provider office? You still have a brick and mortar. Quit driving to all these outreach sites. Let's partner with other communities and extend your practice to them that way. And so that team is really around workflow, clinical informatics, and studying adoption. And so we do telemedicine, we do remote monitoring, we do virtual provider offices, digital urgent care, and I'll speak to that in some more detail in a minute. Care management goes hand in hand with that. So we really needed somebody to navigate all these patients to understand what levels of service they need when they come in the door. And so I'll add into more details, but this is really our population health strategy. So it's not about telemedicine, it's not about chronic disease management, it's not about all these individual services, it's about what does each individual need in totality to really get toward health. And there's a huge component in education as well. And underlying all of this is a component around social services. So it doesn't matter if I give all the best access in the world if it really isn't addressing their environment, their social needs, their transportation needs, and all of those other pieces. So we have a large workforce in this building that are social service, social workers, health promoters, and others that can really understand the life of an individual and really how to make a difference in their life. So when I talked about access, the beauty of having that large footprint in Ascension is that we're able to now look at all of these people that do scheduling at all of our organizations, put them under one team and deploy them in a national, regional, and local strategy. And so they then slowly start having visibility everywhere across our organization. So that a patient, when we can really do guided scheduling then. When somebody calls in and says, I want an appointment, you say, what's more important, your doctor, the time, the location, what do you really need to be able to get the care that you need? And so that's really the focus of this team. So we're looking at it around capacity management as well. There's a reality that we don't have enough healthcare providers to meet the needs. So we've got to load bear that work and understand how to optimize productivity, which is by using a balancing of in-person care as well as virtual care. I mentioned the care coordination and digital health, but there's multiple channels of how people get in and out of the system. We need to be doing our outbound campaigns, reaching out saying, hey, it's time for your mammogram, it's time for your colonoscopy, but we're also at the same time integrating education and other access strategies to be able to really get people the continuity of care that they need and be proactive, so that it's not just a sick care system. So we're at a telehealth conference. I'm going to dive a little deeper into our telehealth operations around our telemedicine, digital clinic, and remote monitoring. But what's good for you to think about is, that's supposed to say team at the top, so on-demand care T. is not correct. I'm sure there's a white box over it. I'm going to go with that. Anyway, this is a really diverse group of professionals that are sitting in this in our building in Austin that are serving needs as they're needed. So if a patient comes in for remote monitoring, say a patient leaves the hospital, they're at risk for readmission, they have multiple chronic diseases, our nurses take that and then decide what services that they need and bolt them on as they're needed. So we may engage with them with just a nurse, we may have a pharmacist, nutritionist, a health promoter, a social worker. All these teams that you see listed here provide different levels of services to have a virtual care team on demand. And so that's made a real big difference. And I'll speak to some of those outcomes in just a second. I'm getting to the 5-minute mark, so I got to go faster. Level 1, 2, and 3 is our remote monitoring program. It's phone, app, and a more intense, longer disease management program. It takes us typically about 4 months to really move the needle on that one. We've had incredible success in monitoring patients in their home environment, teaching them, coaching them, helping them understand when I eat this is actually what happens to my vital signs. My favorite stories are always around holidays when we have all of our nurses having to call the patients and say, what did you eat last night at the Super Bowl? Because your blood pressure's through the roof. And they feel fine, so they would have never correlated the two. But when you can call them immediately real time and they're already ashamed and their head's down, they're like, I couldn't help it, the wings. Anyway, really exciting stuff there. Our hospital services, I mentioned these. It really is a clinical surveillance unit. We can add as many data points. I could monitor IV pumps, whatever I need to monitor. Any device with software, which is pretty much everything in the hospital now, including our mattresses, I can really monitor anything. And so as the teams are leaner and leaner and our patients are sicker and sicker in the hospital, how we can pull some of that responsibility away where we're not distracted and look for themes and trends to be able to intervene earlier and be a part of that care team is really exciting. So let me speak a little bit just to some outcomes, because this isn't good enough to just say, I've put a bunch of telemedicine cards somewhere, or I have 10,000 lives I cover. To me, that's not enough. We have to go further. And so let me just give you some of our numbers from the last year. So our readmission rate, and we've done the most study around heart failure, we still have more to do. We went from a 26.8% readmission rate for our high-risk heart failure patients to a 2.47% readmission rate, and we're maintaining that. That's one. That's a remote monitoring, care coordination, it's all that you just saw overlaid onto these patients. When we talk about access, things that we've been able to do is take physician groups that had a 9 and 10 month wait list down to 2 and 3 week wait list, because we're able to understand who really needs to go in there, maximize primary care, let them stay in their community, and co-manage through telemedicine so that everybody is a part of the care team and patients get to stay in their community. When I think about some of our other numbers around growth, we're able to now extend our services far beyond our original 11 hospitals to now 48 different counties in Texas and continue to expand. So we have the hub in Austin. The outcomes that we've had from there, not only have we been able to improve health and access to care, but we've been able to lower the cost to actually operate this. I was able to pull $6 million out of the operating budget and still expand the services because we grouped everybody together and gave them the technology that they needed. So because of that success, Ascension said, hey, do that some other places. So we opened our second location in Indiana this month. So it's the same type of model. A third one will open later this year. And then we will have a regional and national approach to this, and we'll have that spread out through the rest of Ascension. So a lot more to come, but we're not looking at it as just telehealth and virtual care that sits over here. It's truly how do I weave it through and make it a part of our operating model so that you don't have to think differently, patients don't have to think differently, and we get the outcomes that we want. Okay, so I'm out of time. Whew, okay, so questions now.
Any questions? Ravi?
As usual, you do a great job at your presenting your ideas here. And my question is the patient involvement part of it. Are they in the team?
Are the patients involved?
In the team. Like when you're collecting all this data,
okay.
My problem with this data and the big health systems is patients are not in that. I mean, you are collecting all the data, you see? Where does this flow? And suppose if I'm a patient, I have a Fitbit, and where is this data going? Are you collecting that? So in empowering the patient, a system has to just give itself up to the patient and empower them, and then use that becomes a comprehensive part of it. Can you comment on it?
Yeah, absolutely. So there's more we can do to get the patients involved, but let me start with what we are doing. So we have patient family advisory groups all over, and I rotate around and just engage with them just to listen about, what do you need? What's working? What do you like about this? What should we call this? When we were naming all of this, we actually involved those teams, and it was quite interesting. I could go into that topic too, around what they think when you say on-demand care and virtual care and things like that. So we've involved them at that level. The second level is around all those fitness trackers and their own devices. Bring your own device. That model is one that we support. So anything that they have, we want to integrate that in. So once they are a person that we're connected with, we want all their data points, and as well as information around their family and their home and everything else, so that we can actually make a difference. Because if we start dictating all that and hand them a box that has all this stuff and it's a duplicate to something else they already have, we're never going to get adoption as well. So, I mean, we can do more, and I don't know what that looks like ultimately, but they're really driving a lot of this. I wish I'd had time to show some of the testimonies. They're running around now in their counties telling everybody, you've got to have this. I had one person did a fundraiser in their county so that everybody could have a kit that had heart failure, and they raised $90,000 on their own. So, I mean, that's pretty cool. So that's how we're involving them right now. We've got more to do, though.
I personally come from a health system that's mostly analog right now in South America, using software that's more than 20 years old. What advice would you give for us to be able to leapfrog that part and come to telemedicine right away as a health system? How would you bring what you're doing to South America or an emerging market?
Yeah, so what's been interesting is that everywhere I've gone to help people either set this up or where I've set it up myself and run it, even though everybody thinks they're a snowflake, it's really, there's a similar trend here. We've got healthcare needs, and we've got them, they're unmet. You have to be culturally sensitive. There's definitely differences there, but the underlying health needs and desires of individuals to be healthy are the same. And so I would say that finding those partners and people that have done that to tell you, hey, look, don't spend your time on this. Here's the greatest value, or speed to value is where you ought to go. I mean, there's so many things I did for many, many years that were nice, but not really, didn't show value. And so when I came to this organization, I got approval in January. I opened this building in November, and we went running. So having that somebody to be a sounding board and thought partner with you to help skip some of the unnecessary pieces, but really get the buy-in from your stakeholders locally so that they can say, hey, you've got free reign, go. Here's your guardrails, but run, I think is the biggest way to leapfrog.
Yes. So, again, it's outstanding job. And this is what we are talking, connecting the dots, the population health. So I have a question on the operation side. So looks like you have a call center. So in the call center, you're doing everything together, remote monitoring, transitional health, everything, So are they managed by just the nurse practitioners, or the doctors? And if you get like something on the remote monitoring, are you monitoring that data on the real time? And what you do if something comes up, like anybody has AFib, anything, how you operationally manage that?
Yeah, that's a great question. So our team is everything from patient access reps, which are non-licensed individuals that are doing some low entry of the call center, just taking calls to say, hey, what do you need, and then routing it appropriately. But nurses lead the care team. We have nurse practitioners as well as physicians out there as well. But one of the things you're touching on, our remote monitoring team is monitoring real time. It's not an emergency department, so we tell people we're monitoring this, and there's escalations that'll tell us when we need to intervene. And so we monitor that real time. But one of the problems we were having is with that escalation, getting somebody to act on it fast enough to avoid the patient going to an ER. So we brought a physician in to do just that. So they're managing the patients in the, and they handle all the orders that we need, and then they're communicating with that physician. And the physicians know that when they come on, we're going to escalate to you, but we want your permission to take care of what needs to be done under these guardrails. So we had to develop what those guardrails were, but that's worked magnificently. We've actually closed 2 transitions of care clinics and flipped them completely virtual based on this new model.
Do Ascension patients have access to their clinical notes?
Partially. I'll tell you, here's a disclosure. I think we have, we may have the largest number of portals that there actually is in the world. I don't know. We have hyperportalosis for sure. They have access to their records. We now have an enterprise data warehouse where it's collecting all of that information. We are not on one EMR. We support all EMRs apparently. So with that comes the challenge of having everything. So this enterprise data warehouse is the repository of all that information that then they can have access to with the permissions and rights of each of those ministries. It's a little different everywhere.
Okay, maybe the last question, Rudy.
I was just kind of curious. How do you make? What's your decision making? For instance, if you need more physician providers as opposed to maybe having more support teams, because a lot of times I know when you try to build this thing out, I agree with you 100%, trying to make it central as part of the thing. But the first thing physician says is, now I need more time, or we need to hire more people, because they're thinking it's separate.
So we do a needs assessment in the community and look at what the needs are. What are people coming to the ER for? What are they getting admitted to? What are the gaps? And so mapping out what your provider workforce is in every area is important. Then you know what you need. There's a lot of ways to accomplish your needs, and every state's different on what scope of practice is and who it can be, so we have to follow those rules as well. So we will always go to our providers, whoever that is, and say, okay, here's the problem. Behavioral health, great example. We have social workers, we have therapists, psychologists, and psychiatrists. What do we need more of? And then you have to really get granular to understand what the real needs are. Do we need medication management, or do we just need more social workers to do all the other things, that's what we found. So we've added, actually, we now have 15 in that one building in Austin, and that's all they do is all of our tobacco cessation, drug and alcohol counseling, all the anxiety and depression, and then they escalate up as needed. But it's really working with all of them. I think you have to pull that whole team together to figure out what the mix is, and then you add it. And of course, your comp plans and incentives have to align. You can't have a physician think they're going to want to do this if it's all RVU driven and it's not, and they're not compensated and don't get RVUs for some of this.
Rudy.
Hi. I'm a physician, and I have a question. As a physician working with various healthcare systems, what advice can you give me to convince a healthcare system that this is an important strategic initiative?
I've actually flipped how I say that now. I keep asking them how they're going to achieve their strategic plan without me, and not me personally, but without this. And I'll tell you, it's hard because the mindsets are still in an acute health system. If you're working with a health system, it's still about hospitals, and it's beds filled, and it's people in the operating room. And that's a priority. And that doesn't go away, and that need doesn't go away. But if you're really going to get to population health, and you're really going to go at risk, then none of that really matters. That's failure. And if I'm successful, I actually do cannibalize some of that. But we've got to figure out the balance of that. And so, I think you have to be pretty bold to talk about what their real problems are and what's happening in the market. There's probably some competitors that are starting to make them nervous and play off of that as well. We can have a whole conversation around that, because that is a challenge. And they've got to believe in it, or you'll be in an uphill battle the whole time.
So Kristi, can I ask you one last question? What advice will you give to these people in other healthcare system, things they should not do? Because maybe they will naturally they want to do something, but from your experience, they should really just not do those things.
Well, the not would be not to give up, and just keep going. They're going to say no, and you just shake your head and go, okay, and then do it anyway. I love that model. I get in trouble for that one frequently. But save them from themselves is really what we're trying to do. And pursue where you're trying to go until apprehended. So that would be my motto.
Awesome.
But don't tell any of them that.
Thank you so much, Kristi. That was good. Awesome. Okay.